Well, welcome everyone to Sunday night's national webinar series. Tonight, Joe's going to be doing glaucoma, yes or no, part two, and optic nerve conundrums, the B side. As you know, Joe is very musically oriented, and that's where that title comes from. Our presenter tonight is Dr. Joe Sowka, who currently works at Venice in Sarasota, Florida, at Center for Sight, a large medical surgical practice that focuses on glaucoma and neuro-ophthalmic imaging. In 2023, Joe was ranked #1 optometrist by US Newsweek. Joe is a founding member of OGS and Optometric Retina Society. Joe, the podium and virtual floor is all yours.
Well, thank you, Greg. I'm going to start a little bit differently. I'm going to start right off with my disclosures. I am on the Advisory and Speakers Bureau for Bausch & Lomb. Everything has been mitigated. I've got no financial interest in any disease, product, instrumentation we might talk about. And as we all know, I'm a co-owner of this Optometric Education Consultants. Well, let's go back now to the title so I can explain everything and everybody knows where we're going to go and lay out the framework for tonight. A few weeks ago, I did a lecture called Glaucoma Yes, Glaucoma No. And that really focused on disc analysis. And for those who saw it, I'm not going to go over the same material. For those that didn't see it, I put the link to that lecture from our YouTube channel in the chat room. So it is there. You can find it. If it's for some reason it's not there, Greg, if you can find and put it in, but I think it should be there. You can see what we talked about it in quote unquote part one. Now, you never know what is going to resonate with somebody. Many years ago, when I was first teaching the glaucoma course at Nova University, where I was faculty for 28 years and 2 days, I was going over disc analysis in the glaucoma course, and I just went over everything, taught the students, and I put up a lot of nerves, and I said, tell me, can you say, is this glaucoma yes or glaucoma no? Meaning that we should be able to be good glaucoma practitioners making diagnoses based upon optic nerve appearance. And for some reason, it was very natural. This came out one day and it became part of my course. And to this day, it still resonates with students and they still bring this up, glaucoma yes, glaucoma no, when they see me or on Facebook. So one never knows what's going to resonate with a person, Greg. You know how it is? And I'll give you a nice example. About a month ago, we were doing our Sarasota meeting, CE Sarasota, and Greg was lecturing. He was cruising along and doing great, and I was breaking down my computer at the head table, and I was a little clumsy, and I crashed the whole system. Everything went down. All of a sudden, all the screens in the room went black, and Greg looks at the screens and turns to me and said, "Did you bump something?" And my response was, "Yeah, probably." And we got it fixed again. But Greg, how many people came up to us and said that like resonated, like the fact that the whole thing crashed and we weren't bothered by it? How many people said that?
Yeah, well, that was quite a few. I was kind of shocked by how many people came up and said that. So,
And at one point I said, Greg, maybe we should put it into the act to do it every time. Now, I also know we are able to finish all the cases, and I realize I've got a number of lectures where I don't get to certain topics, I don't get to certain cases because we're at the end, and we always run out of time. Let me on Tuesday, Greg ran out of time to finish his lecture, and we always have to circle back and do something. So I thought I'd go back and pick out the cases and pick out the topics I never get to do. I put them together, but I just never get there. And you might say it's like the B side of a 45 RPM. So, the B-sides are the cases we're going to talk about, the ones I don't get to talk about very often. Now, for those much younger than us, A-side, these are from 45 RPMs. A-side was the quote-unquote hit song, the one that the producer hoped would become the big hit. And the B-side was often just slapped on to take up vinyl. So A-side and B-side comes from vinyl 45s. Now, if you know what this is, you're old. If you've used this, you really are old. If you have one of these, you're just a hoarder. Get rid of it. Now, let's look at some classic rock
Well, Joe, you got to
A-sides.
explain what it is. I'm sure someone out there doesn't know what it is.
Oh, that was what we put in here to turn the turntable into something that can handle a 45 as opposed to the 33 and a third RPM. Good point. So in classic rocks, we got these A-sides, these big hits from big performers. But what did they slap on the backside as an afterthought? Bruce Springsteen, A-side, Dancing in the Dark, B-side, King Cadillac. Good song. Beatles, Hey Jude, A-side. What was on the B-side? Revolution. Paperback Writer, again the Beatles, A-side. That was the hit. What was on the B-side? Rain. Creedence Clearwater Revival, their A-side, what they thought was going to be the big hit, when it was. Proud Mary, B-side, Born on the Bayou. Simon and Garfunkel, Cecilia was the A-side. That's what they thought was going to be the hit. What was on the B-side? Only Living Boy in New York. Great song. Fleetwood Mac, Go Your Own Way. That was thought to be the hit song. On the other side, Silver Springs. Chicago, Make Me Smile was the A-side. B-side, Color My World. And one can argue that was probably the bigger song for Chicago. And again, the Beatles, Hello, Goodbye was the A, and the B was I Am the Walrus. So I'm kind of hoping, Greg, that my B-sides are like these and stand on their own and are enjoyable to the audience. So glaucoma, yes, or glaucoma, no. Now, previously when we did this, we're just doing it on optic nerve appearance. Now I'm going to put some information in there for you to analyze and decide, is this glaucoma or is it not? Glaucoma, yes, or glaucoma, no. 46-year-old female had been diagnosed and treated for glaucoma in Jamaica, is on brimonidine 0.1% and latanoprost timolol fixed combination, available in Jamaica, not in the US, both eyes. Pressure is 14 and 16. Average pachymetry, large CD ratio. Fields were unreliable, high false positive, abnormally high sensitivity. It wasn't her gift, couldn't do fields. And here are the optic nerves. And an OCT. And I'll let you all kind of look at that for a second and determine, based upon the information that you see here, is this a glaucoma, yes, or glaucoma, no? So, Greg, that's polling question number 1. Glaucoma, yes. Glaucoma, no. Simple. She's been diagnosed, but do you agree? Does she have glaucoma? Glaucoma, yes. Glaucoma, no.
Polling question is open. Answers are rolling in. Opinions are rolling in.
Excellent. So we can see the ganglion cell analysis. We can see the nerve head, the nerve fiber analysis on the Zeiss OCT.
Yeah, Christina put in the chat. It would have been good. I told you Joe was musically oriented. He just built this. I didn't know that was coming in. She said maybe I should put the picture and ask people what that was, Joe,
What picture?
of your little insert for your 45 that so that could fit on and play. All right, let's go back to the poll. I think we're good. And I'll display it. We have 79% saying no.
Excellent. Now, one thing I want to point out here as we take a look. Well, I agree, glaucoma, no, or I'm very suspicious not. Good looking nerves, good symmetrical rim tissue, stop all meds. Pressure shoots up to 17 and 18, but what I want to point out is look at the disc area. In excess of 4 millimeters. These are huge nerves, megalopapillae. And you can understand how this person got diagnosed. Suspicious nerves, turns in a bad field, bada bing, bada boom. Now you have glaucoma. There's a population-based study in Greece, the Thessaloniki Eye Study, looked at over 2,500 people over the age of 60. In a population-based study, there was about a 50% undiagnosed glaucoma rate. Now, if you are faced with the question, what percentage of patients in glaucoma, Germany, England, any industrialized country, what is the percentage of undiagnosed glaucoma? It's always going to be 50%. But interesting, they found about 2/3 were overdiagnosed. Only a third of the patient had been diagnosed and treated with meds, laser, and yes, even surgery could not have their diagnosis confirmed. So you have to understand overdiagnoses do occur in glaucoma. Now, she's an 86-year-old female. She's pseudophakic, 20/20 in each eye, no afferent defect. Her maximum pressure is 23 and 24, thick-ish corneas. She's got COPD, hypertension, type 2 diabetes borderline, probably a little bit, maybe a metabolic syndrome. And we can see her optic nerves, and these are old photographs. I'm not even sure what camera in our practice took this. Probably don't even have it anymore, but you can see that, she does have some compromised nerves with some parapapillary atrophy. And here is her optic nerve, RNFL and GCC. We have some abnormalities here in the GCC, a little bit more in the right eye. We have some areas here that are borderline, but in our glaucoma prone zone up here, we do have some departures from the normative database. So 86 years old, 23 pressures. We see her pachymetry. This is her OCT, and this is her field. So this is her
Hey, Joe,
field.
before you answer answer the question, go back to the OCT real quick. And can you point out the rim area there, or I'm sorry, the disc area, which right below the rim area?
Right
and it
there.
says 1.72 in that eye and 1.81. I just want to have a discussion on the first one. You said it was huge. In what I use in practice, I'm just curious what you use. I use as average 1.5 to 3. It's a little bit big. It's a little bit smaller. It's like the average is like 2.8, but in my head, I just make it easier 1.5 and 3 because if I double 1.5, it comes to 3. Is that what you use for disc area, or do you have different numbers that you like to use for that disc area? Because these ones here, if I use 1.5 and 3, it falls into the average. And if it's smaller, that would be micro. And if it's bigger than 3, it would be macro. So just curious.
Yeah, it's about a 2.8 is what I consider upper limits. My upper limits are normal, but I'm not sure I really even think about it that much.
So for those that are out there, since Joe mentioned it, if you want to just put it into your head or write it down or however you want to do it, your average disc area is that 1.5 to 3, or the average when you look at literature is 2.82. I'm not sure if you want to remember that. So just 2 to 3, and then that would be a good one. So go ahead.
There's her nerve, her OCT, her field, and our polling question: is it glaucoma yes or glaucoma no?
The question is open.
I'll just scroll back through some of the images. So what do we think, Greg? We got a trend?
They're rolling in. The trend is good.
Hope everybody's enjoying. I think we got about 12 more polls. Keeping it interactive today.
The trend is pretty well split. 47, yes. 53, no. So you're not as decisive as the first one.
I'm going to go with this as a glaucoma yes, because we have some abnormalities here in that glaucoma prone zone. We have some corresponding GCC abnormalities. So this is actually a glaucoma, yes. And it automatically brings me to polling question number 3. If this is a glaucoma, yes, what do we do with her? Treat with meds, treat with SLT, observe, or would you do something else?
What was the current treatment as a reminder?
There was no treatment at this point.
Okay. Check the chat box real quick. And a couple people said they couldn't answer. Remember to click the poll button. It's on the right side so there's chat and polls. Make sure you click on that when the poll is open. I see someone figured it out. And let me go back to the polls and display. We've got 51% doing meds, got 30 or 29% doing SLT. You got 18% going observe, and you got 1% going with something else.
All right. Well, this is actually a person who was actually just observed, and what we can see happens over time, 21, 23. I think what happened was she had a lapse in her exams. And we can see that it wasn't so impressive at the first, but we can see there's reproducible field loss. In her other eye, there really was none. We don't have an extrapolation. We can see this is really pretty well flat, but now she's almost 90 years old and is not being troubled by this. So when we take into account severity of disease, age, one of the options out there could be just observation. We learned that from the early manifest glaucoma trial, that a period of observation is actually acceptable for mild newly diagnosed glaucoma. So we decided, after discussion, risk, benefit, and alternatives, to monitor without intervention. And at this point, nothing has changed.
If you stay on those, Jeff, you just if the audience just looks at the right eye, if you look at the mean deviation, she started off as a minus 1.87. And then 2 years later, or a little less than 2 years later, she's in the plus range. She's gotten better despite the defect that's sitting there. Another visual field that I like to point out is that when that hits minus 32, that's a blind eye. 0 is perfect, so they're hardly showing any defect. And then go down to 2024, she's plus 0.38 on average on this visual field. So I certainly don't see anything at 90 years old too concerning there.
Exactly. Anything in chat, Greg?
I don't think so. I'll look.
All right. Well,
Oh, hold on. They're
hold.
popping in. They're popping in. One can't answer. Okay. Why was the second one glaucoma? There was a mention of a glaucoma zone. So you might want to point out the glaucoma prone zone there.
Glaucoma is a disease that affects the nerve superior temporal, inferior temporal first, not nasal, not temporal. So the superior temporal, inferior temporal is what we consider to be the glaucoma prone zone, or the area on the nerve that's prone to damage.
And they're thinking because the lamina cribosa has a different structure, superior, inferior, versus kind of nasal and temporal. It's a little structurally sound, thinking that there might be some bowing, some shifting, choking off the axons, superior and inferior. Lots going on with glaucoma. It's a chronic disease. I try and teach that things are not linear and binary, but that's kind of why we're thinking that's where that glaucoma prone zone is. Another question rolled in, Joe. What field analyzer was used?
Humphrey
So that was
field
a
analyzer.
Humphrey. He did CETA. I saw it on there, CETA Fast, I
Mhm.
believe. That was a Humphrey field. Again, not claiming any superiority on that. on that out there. And then, so did she really have glaucoma?
She had glaucoma. She had disc damage. She had nerve fiber layer damage, GCC damage, and field damage in her right eye. Her left eye had not really succumbed yet. All right, he's a 52-year-old male, 2020, no afferent defect, thin corneas. Gonioscopically open, no abnormalities. His pressure is ranged over several visits, 19 to 26 right eye, 19 to 23 left eye. Hypertensive, type 2 diabetes, high cholesterol, and has a heart stent. Use atorvastatin, losartan, carvedilol, and Ozempic.
Did
And
we go
here's,
over whether they would treat or not treat?
pardon me?
Did we go over if they would treat or not treat?
Yes.
Did we go over
We chose not in the
meds,
last one.
meds, SLT, observe? Okay.
Yes, we did.
All right.
All right, so here's our patient. Here is his OCT. It looks very good nerve fiber layer. This red area here corresponds to a loss of data, so that's not an abnormality. That's just missing data, so we don't worry about that. Our B scan is pretty good, so we have something maybe here, but a good nerve fiber layer. And here are his visual fields. So risk factors, ignore this because it's just missing information. Nerve fiber layer looks good. GCC may be a little suspicious here. Here are his fields looking very good, very full. And here are his optic nerves. I'll let you digest that for just a second. That brings me to polling question number 4. Is this glaucoma yes or glaucoma no? And as you launch that, I'm going to go back to the optic nerve because I want you to really critically analyze that optic nerve and tell me what you think. I guess they're rolling in, Greg?
Yeah, I was just checking the chat box. Yep, they're rolling in.
So is this a glaucoma yes or glaucoma no? Thin
Let's see that.
corneas, somewhat higher pressures, some ischemic vascular disease, a mostly good-looking OCT, though there may be some abnormalities here in the left GCC. Very good visual field taker. And there are the optic nerves. So let's call it, Greg. What do they think? Glaucoma yes or glaucoma no?
86% saying no.
All right, well, the important thing to look at here is this large bare area in here, and that is actually a large wedge defect, which is unfortunately not picked up here so much on the nerve fiber layer, but we're getting a hint of it here. And that's the importance of putting everything together and looking at everything, including optic nerve and disc photos. He has I said, a large wedge defect. So he was actually a glaucoma yes, and he was put on medical therapy with a prostaglandin.
Which is going to lead me to kind of mention to the audience that a lot of us have kind of wide field imaging in the practice. And with that comes a little bit loss of the quality of the nerve fiber layer that's out there. Luckily I have 2 cameras in the practice. I can still do Optimaps, which is, kind of a wide field imaging. And then I do have IDEN, it's with eye care, and man, are the images beautiful to be able to do that. Now, not everyone has a luxury, but we just want to cement to have 2 cameras. But I want to kind of mention what Joe is saying here is if you don't have a good quality camera, if you don't do kind of multimodal testing, visual fields and optic nerve heads and OCTs, we kind of got away from photos, you probably can miss some glaucomatous changes.
Well, here's another glaucoma yes or glaucoma no. 80-year-old female, comprehensive exam elsewhere in our practice with another office in our practice, another practitioner. Multifocal IOL doing well, pressure 14. Was seen to have suspicious nerves in the left eye, and unfortunately, I don't think I have a photograph. OCT was performed, came out suspicious, and plans follow up with fields. Fields were done. Interpretation full right eye, likely full left eye, pressure 10 and 11. Plan comp exam 1 year with repeat fields. Now let's take a look at what we have here. And we have an area up here on the GCC that corresponds to this black area. So that is actually missing data. So that really doesn't so much count, but there is a departure from the normative database in the glaucoma-prone zone in the right eye. In the left eye, there's also a departure from the glaucoma, from the normative database in the glaucoma-prone zone superior temporal, but a more robust abnormality in the GCC. And by looking at the B scan, looks like we have all the information there. We take a look at the visual fields, and it is within normal limits right eye, outside normal limits left eye, and there is an inferior defect which seems to correspond to what we have right here, although she has relatively normal intraocular pressures. So Greg, that brings me to polling question number 5. Is this a glaucoma yes or glaucoma no? And as people are thinking about it, I'm going to go back. 14 pressures at one visit, 10 and 11 at another visit. It was interpreted that her field was likely full in the left eye. Unfortunately, photos were never taken of this patient initially, but there are some abnormalities on the OCT in the nerve fiber layer, and especially in the GCC in the left eye. And we seem to have a certain functional concordance, functional structural concordance here. So is this a glaucoma yes or a glaucoma no?
Joe, go back to your OCT, please. What I want to point out on this B scan of the optic nerve to everyone, this is why this is a funny looking nerve or a hard one to call. Look how shallow that cup is on both. It's not a well-defined cup. So it's hard to judge your cup to disc ratio. If you go back and look at the other OCTs, but I was looking at those because I was looking at that for quality. They went over, down, over, back, up like we'd expect. Those are super, super shallow. It's going to throw off some of the metrics of the grayscale there, how it's defining the cup. Show them on the on our nerve fiber layer scan where it's defining that cup in the gray area. Look, see how it's defining the cup there, and you look at those nerves over there, you can see it's going to have a tough time because how shallow that is on that P scan. So be careful with those numbers in that optic nerve head analysis, but GCC would be good and your nerve fiber layer would be good.
So what does the audience think, Greg? Glaucoma yes or glaucoma no?
They went yes.
I agree.
74% and 28% say no.
Yep, this is the glaucoma yes. I'm not really sure what my colleague was thinking about this, but it was a glaucoma yes. But no harm, no foul, because the patient had disappeared for about 3 years. So let's take a look at what happened. This is where the patient was in 2022, and we compare it to 2025. I'm not going to get into the details of the number. You can see there's missing data here corresponding to that. Much better in this, and you see how it goes away. So over the course of 3 years of non-adherence to visits, nothing in the OCT changed. And this is what happened in the visual field, 22 to 25, virtually no change in the right eye, and the glaucomatous left eye really shows not much of a difference here. So this is the kind of patient we question. What do we do now? If we decide she's glaucoma, yes, do we treat her with meds, treat her with SLT, or observe her, or do something else? Now she's 83 years old, and we see what's happened to her over the course of 3 years of not being seen. and pressures, it appears to be peaking at about 14. Do you want to treat it with meds, treat it with SLT, observe, or do something else?
You get back to the visual fields, her defect actually got better in the mean deviation side.
Mm-hmm.
Minus 2.75 up to 1.6. And then the other eye was, do the other eye for me. Minus 1.3 up to 0.22, minus 0.22.
Which is a challenge because this is a psychophysical test that involves patients' involvement. So what do people think, Greg? What are we going to do? Treat with meds, treat SLT, observe, or do something else?
Treat with meds 21%, SLT 29%, observe 47%, and something else 3%.
All are good. All are good options. You can treat with meds, SLT is fine, observe, risk-benefit alternatives were discussed with her. She's been stable, pressures are relatively low. We're going to observe her. And of course, she's now 83 years old. Now let's make it really fun. Let's try to diagnose glaucoma when the nerves are funny looking to begin with.
Do you want to take the questions?
Oh, sure.
Because they are rolling in. So what analyzer? We covered that one. Did she have early glaucoma? Could we not monitor this patient? I'm not sure which one that was. It seems that the retinal nerve fiber layer loss in the left eye does not touch the optic nerve. Does that need to reach the optic nerve head?
I think that was a 52-year-old. I actually felt that it really did. It made it virtually to the parapapillary area.
So that's a good point that our colleague is pointing out. If the nerve fiber layer defect, where they're going is, it could be a pseudo defect. If it doesn't make it all the way back to the optic nerve, to the neuroretinal rim, then it would be kind of a pseudo wedge defect. And that's where our colleague is going with that question.
And those pseudo defects tend to be very small, not broad like that 52-year-old. Any other questions?
Oh, yeah.
Okay.
The wedge defect shown. That's still the wedge defect shown. That was a continuation of the other one. Why not observe the 52-year-old patient? Glaucoma is, why not observe the 52-year-old patient? Question mark. Glaucoma is a progressive damage of the optic nerve. The field and OCT were normal.
Field and OCT were normal. The nerve fiber layer was not normal. There was a defect in that. It wasn't picked up in the OCT. Has not shown up in the visual field yet. He's 52 years old with an easily modifiable risk factor of a pressure in the low to mid-20s. So that's where we treated him.
Are you seeing more of these cases with lower IOP and patients with low blood pressure and or sleep apnea?
I don't always check blood pressure. I don't know the status of the sleep apnea, to be honest with you, in many cases.
So do you think you're not seeing in your practice going to OGS, or do you think you're seeing I guess the trends as that's out there? Are we seeing lower IOPs, and you do a lot of optic nerve neuropathies? I don't really see a trend out there, Mark, with low IOPs and sleep apneas. But I'm certainly not an expert in the normal tension glaucoma arena. What's the latest that's out there? But Joe, any comments on that?
No, I think and when the pressures are lower, there's probably some other systemic issues that could be at play, including what the two that were mentioned. Are we caught up?
Nope. I'll let you know in a second. You've mentioned 10 is a significant inner eye difference on OCT. Is that for average retinal nerve fiber layer or any of the OCT stats?
Really, any of them.
Yeah, so when you're doing GCC, it's a much smaller number. When you start getting to that 10, remember it's plus or minus 3. If you repeat it back to back, most of the OCTs out there that people have, unless you get into some of these really new ones, they're getting down to 1.5 and 1 micron of variability. You can take an OCT and just do it 3 minutes later, it can have a 3 micron difference. That's the best that we got right now, unless you have one of the newer ones, which you can get down to 1 and 1.5 microns. So 10 is a good number. Remember that this is what I tell my patients all the time is I like to look at symmetry. You know, arthritis can be worse. Arthritis is usually in both shoulders. It's just worse in one shoulder than the other. Arthritis in the knee pain, hips, people get done. They have one done first, then the other. Disease is usually bilateral. Glaucoma is bilateral, but luckily it is asymmetric. So that's a good number to go by. Very rarely is the disease going to go down equally in both eyes. So when you're looking at these tests, that's why asymmetry and the repeatable of that asymmetry is really important. So 10 micron difference is a good change because of the variability within the instruments that's out there. And as Joe was mentioning, sometimes you have a good technician, you got a high quality, low quality, data's missing. And remember, the other part is the vitreous is alive. That vitreous can tug and pull, and the vitreous can make a few micron changes. So 10 is a good number. That's the explanation out there for your neurofiber layer and your GCC. And then the last question, Joe, is do you take into account family history of glaucoma?
I take into account family history of glaucoma a bit, if it's a direct, brother, sister, father, mother, children. I also take in a fellow eye history. If it happened in one eye, I assume it's probably going to happen in the other if they have symmetrical pressures.
The add-on I'll do to that question is I will do family history if you can confirm that it's glaucoma,
Mhm.
right? So there's a lot of people out there for a couple of reasons. One, they have glaucoma. What did they do? Well, they went in the operating room, took something out, put an implant in. Okay, that's cataract. It's not glaucoma. The other is there's a lot of overtreated, a lot of glaucoma that really isn't glaucoma that's out there. So my caveat, William, would be is that make sure it's glaucoma if that's what the patient is telling you, that it's not a cataract surgery and they had surgery for it. Or if it is glaucoma, maybe it should be something in your practice or you can lay eyes on. And case in point, I had a glaucoma patient come in on Wednesday and her daughter brings her all the time. And I said, look, you're in your 50s, get checked. Her pressures were elevated and she had damage already. And on top of it, she had some basal cells on her that I never really looked close at her whenever I was chatting with her. She's over in the corner. We found a couple of basal cells and we got some glaucoma. So mom had glaucoma, so lean on the children to get in there and get checked.
All right,
All right, Joe, I'm done and you're
I'm
caught
gonna
up.
I'm gonna pick up the pace a little bit. We're gonna look at anomalous nerves because we can't use the same rules of disc analysis that I talked about previously. Abnormal anatomy is often going to be abnormal OCT. There can be field loss and it can be congenital or it can be acquired. We've got to look at clues, risk factors. We're probably going to make a mistake. We're probably going to make diagnostic errors, but we have to ensure the errors have the least detrimental effect to the patient. 72-year-old male, he's amblyopic in the right eye and bilateral dense cataracts, PSC. Undergoes cataract surgery, left eye, comes out 2050, no complications, very unhappy with the outcome. He brings old records with him. It would say in follow-up and post-op visits, patient unhappy, patient yelling. Then the cataract surgery suspects glaucoma, refers him to the glaucoma specialist who diagnoses advanced normal tension glaucoma, which I think is the patient rope-a-dope or kick the patient and kick the can down the road. If they're not happy, get them in somebody else's office. They can be unhappy there. Average pachymetry, peak pressure 22. Refer the glaucoma specialist, treats to the low teens. Now, here are the challenges. He doesn't believe he has normal tension glaucoma. He's a semi-retired attorney who has time, money, and excellent internet access, and like a philosopher searching for truth, will stop at nothing to discover what is wrong. Now, here is optic nerves. It's very blurry because he's got a cataract. We can see he's got a markedly anomalous congenital disc, a tilted disc syndrome in the right eye. He's got a significant tilted disc syndrome in the left eye, which is a coloboma, or what I'd like to say, he certainly does have a congenital oma. And here are his fields. Now we can see that this is not a glaucomatous type of visual field in the left eye, potentially a glaucomatous field in the right eye, but if we look, the nerves look relatively symmetrical. So Greg, that brings me to polling question number 7, glaucoma yes or glaucoma no? There are his fields. Field loss doesn't necessarily explain his vision in the left eye. I will tell you the macula OCT was fine. And here is optic nerves.
While this polling question is running, a few weeks back, we did something about glaucoma, and you asked about peripapillary atrophy and if we've seen it changing in a glaucoma patient. I'm using Flickr photography. I've had it into my, well, I've had the camera in my practice for now a little bit over a year, maybe a year and a half. And now the patients are coming in and I'm using this same camera and it's got to be able to flicker back and forth. I've got 3 really cool cases of where you can see the peripapillary atrophy changing. We'll throw it on one of the one of the webinars. But if you put them side by side, you can't tell. When you flicker it, anyway, you can tell.
But this is not really peripapillary atrophy as much as really a collobomus.
Yeah, that's a
formation.
coloboma. I get it, but that's what reminded me of.
So
if I ever seen it, now I have.
what's our trend? Is it glaucoma yes or glaucoma no?
We have 62% saying no.
All right.
61%.
All right. All right. Let's talk about what happened with him. Evaluation, including I got neuroimaging on him. It was unremarkable. And like a philosopher, he travels the country getting consults and gets conflicting opinions. The only thing I found was there's a mucus retention cyst in his sphenoid sinus. A neuro-ophthalmologist said, yeah, that's probably causing compression of his optic nerve. An ENT specialist said it is absolutely not involved at all. He's got significant field loss. I don't know. The answer is I don't know. He maybe does have a congenitally, but he maybe also does have glaucoma, or what I call a doubleoma. So my option was to continue his prostaglandin treatment. First, do no harm. I can't say definitively he does have glaucoma, nor can I definitively say he does not. So this is a glaucoma I don't know. Now, this brings me to a 38-year-old female who referred me for glaucoma evaluation many years ago after failing a LASIK screening, both for her funny-looking nerves as well as her thin corneas. She had been treated previously in her mid-20s for glaucoma with a beta blocker. Her pressure is in the mid to upper teens with no medicine. She had not used medicine for a number of years when I saw her. And let's take a look at her optic nerves. And we can certainly see there is an oblique rotation going on in each eye, more significant in her right eye than her left eye, and a bit of a nasal step that goes with it. Now, I can't tell. I don't think anybody can tell without previous records. Is that field loss due to the congenital abnormality here? Or is it a changing or progressive anomaly? So that brings me to polling question number 8. Is this a glaucoma yes or a glaucoma no?
Let me see if it worked. Let me go to here. And, well, I'm just going to open this one up. I'm going to open this up. Use polling question number. Oh, no, here it is. Hold on. I'm going to close it. All right, it's open now. Polling question 8 is open. Well, I didn't assign it in the process of doing this. You have to assign it to a webinar. And I knew you were coming up on 8 and I couldn't find it. So I went into the program real quick and found it and assigned it. So
and that's why when things crash on us, we don't get worried about it. There are her optic nerves. There's her field. Thin corneas and mid to upper teen pressures.
Ooh, those are some fun nerves.
How are we trending, Greg?
Give it a couple more minutes. They're rolling in. Let me check the questions here. Do you have OCT of the nerve? I missed that question. I'm not sure what case that was. Do you have an OCT of the nerve?
On this one, I do not to share with us.
Did you do a 10-2 white visual field due to decreased vision?
In the previous case for the attorney, the answer is yes. And the macular OCT on that fellow was normal.
You could he have mixed up which eye was amblyopic?
Nope.
Okay. So you're caught up on that.
Questions?
And
All right.
now the polling question. There we go. We got numbers. We got 60% saying yes.
All right. Well, my approach was congenitally anomalous nerves with field loss, and we had a discussion risk benefit alternatives to treatment. She agreed to be observed, so I did monitor for about 11 years, and nothing changed. Then after about 11 years or 12 years, she started to show some change in her visual field. And think about it, here's a person who's 49 years old with thin corneas, high teen pressures, and she ultimately did progress and develop glaucoma. So then I put her on a prostaglandin analog, and we brought her pressure down to 9 and 10. So I think that she was congenitally anomalous and developed glaucoma over the course of 12 years. So we're able to avoid treatment for about 12 years on her. Now here's one very similar yet so different. 45-year-old females referred to me for a glaucoma evaluation. Pressure never exceeded the mid-teens. Average pachymetry. Previous doctor had tried several medicines, had no effect, and her optic nerves look like this. I'm just going to go back to the first one. You can see how very similar the optic nerves are in appearance. And interesting, what I think the more dramatically appearing optic nerve has minimal field loss, and the less dramatically appearing optic nerve has major field loss. And I don't have a polling question on this one, but I'm just going to say the conundrums. Is a field loss due to an anomaly, glaucoma, both? Is this progressive or congenital? We don't know until we follow the patient over time. Her mid-teen pressures and poor medical response was challenging. Question is, do we treat this person or do we observe? A person that has this type of field loss, I feel comfortable observing for a period of time. But a person who has this type of field loss, I do not. So our alternative was to try some other medicines, and I actually did find one branded prostaglandin that did work better than the others. It did lower her pressure by about 30%. I followed her for about 2 years. Nothing changed in her visual fields in that 2-year period, being treated with a seemingly effective prostaglandin analog, and nothing changed. So the question is, if this were congenital, maybe it wouldn't change to begin with. But when we are going to have a risk of central acuity loss in a situation like this, I think we need to err on the side of caution and treat. Anything in the question in the chat box, Greg?
Yes. I just have to go back to find out. It's this one right here. It says, which prostaglandin worked better and why?
You're asking me to go back into my memory from a long time ago. I think it was Lumigan 0.03, because that's what we had. We didn't have 0.1 at that point. And why? I don't know. Different receptors. All right.
Trabitan and xalatan are the same type of molecules. They're esters. Lumigan is an amide, so that's the only thing that's different between the two. It takes a higher percentage of the Lumigan product to get through the cornea because it is an amide, where the esters use plasma cholinesterase, and you can use lower percentages. That's why there's an extra 0.1 versus 0.5 or 0.4. But that's really the only differences. And then, like Joe said, plugging into the receptors.
Well, let's talk about over, under, and misdiagnosing. And now I'm going to talk about some non-arteritic ischemic neuropathies upcoming, optic neuritis and the relationship with pain, some mystery neuropathies. But before I do, I've got one last glaucoma patient to talk about, a 54-year-old male who had been referred to me for glaucoma management, had been diagnosed with glaucoma 6 years earlier in another country, underwent no treatment. I don't know why. His pressure or his vision is 20/30 right eye, hand motion left eye, complains of slowly progressive vision loss in his left eye, and has pressures 30 and 23 when I see him. Now, when we take a look at this patient, what do we see here? Large nerves, large CD ratio, but distinct pallor in the left eye compared to the right. And the cupping of 0.8 does not match hand motion vision. And I can tell you his OCT, I don't think I have it in here, was normal in the right eye, only mildly abnormal in the left. That's why fields were so important, because we still need to do fields in the age of OCT imaging, because sometimes it's not glaucoma. What do we see is a bitemporal defect with a junctional scotoma from a large pituitary adenoma that is compressing the chiasm, as well as the posterior aspect of the left optic nerve. So it brings up that fear many doctors have. The patient who we think has glaucoma, treat for glaucoma, but ends up having an optic nerve tumor. And we tend to be most worried about these in the normal tensive range. I think it's even more challenging when they have a modifiable risk factor of elevated intraocular pressure. But here's a manuscript. It's 1998, Ophthalmology, Big Blue at the time. This is one of the best manuscripts in all of eye care. And I call this the Let It Be or Hey Jude of manuscripts. It's the cupped disc, Who Needs Neuroimaging? And this was a collaboration between the glaucoma department and the neuro-ophthalmology department at Bascom Palmer Eye Institute. And what they did was they looked at a series of patients in the glaucoma service with normal tensions who were unusual in appearance and had undergone neuroimaging of some sort as part of their evaluation. And then they compared it to a series of known tumors of compressing the visual system that were in the neuro-ophthalmology department. And they compared and contrasted these. And it was a wonderful manuscript that I go by to this day when I start to wonder, do I need to do neuroimaging? And what they found was, in making these comparisons, these funky normal tension glaucoma patients versus patients with known tumors, they found that the glaucoma patients were older, had better or normal visual acuity, greater vertical loss of the neuroretinal rim, also known as notching, and more frequent disc hemorrhage. In fact, disc hemorrhage was 100% specific for glaucoma. Not one tumor patient had a disc hemorrhage. Less neuroretinal rim pallor and field defects along the horizontal. Now, patients who had tumors, they usually had visual acuity of less than 20/40, or we can say they had vision incompatible with their optic nerve appearance. They had vertically aligned field defects, optic disc pallor and excessive cupping. The rim was pale, as we saw with this patient, and they tended to be younger. So more indicative of a compressive mass lesion than glaucoma are younger patients, people who have unexplained vision loss, vertically aligned field defects, and pale nerves. And that's it. I don't neuroimage all my normal tension glaucoma patients. There was a time we used to do that many years ago. We went on the neuroradiologic fishing trip, and we really really kind of wasted resources. I only think about tumors when they meet these requirements. And they meet these requirements, I am going to neuroimaging. A cupped nerve with a pale tissue, with pale nerve tissue, I'm going to neuroimage. A pink nerve with notching of the neuroretinal rim, that's glaucoma. I'm going to treat it as such. Greg, anything come in?
I had three pituitary tumors last year. All had low testosterone levels. I think it was just a comment. And then I'm going to make a comment just to kind of tie everything together here is that remember, glaucoma is an optic neuropathy. It happens to be the most common optic neuropathy. So that's kind of like I love what Joe's doing here, kind of taking our most common optic neuropathy and now morphing into these optic nerve conundrums. And kind of, we don't image glaucoma every time, even though it's an optic neuropathy. We image the normal tension and with those guidelines that he just gave us. And now we're going to move probably into some of the other types of.
But I remember early in my career, you had normal tension glaucoma. They got an image in many cases. And maybe once or twice you catch something by accident that turns out to be a coincidentaloma. But I don't do it on every patient. But I'll even do it. I'll do it on high tension patients if they meet certain requirements, such as pallor. But Greg, if you're in doubt, why don't you just send the ER? They always get it right, right?
Yeah, exactly. Yep.
Here's one. My wife had this patient. I was working with her on it and helping her out because we're in the same office. 36-year-old male, sudden painless vision loss, left eye 1 day duration. 20/20 right eye, 2200 left with an afferent defect. Type 2 diabetes on metformin. We see the visual field abnormalities there. All right. We take a look, we can see that he has some diabetic retinopathy, some cotton wool spotting here. But in the right eye, he's got a marked amount of disc edema, no symmetry between the right and left eye. I'm not going to call this a macular star because he does have exudates from diabetes. He's young, he's got diabetic retinopathy. He's got a swollen optic nerve. We can see serous detachment into the macular region. All right, so this is a person who's got a world of hurt. We have
Joe,
to
point that out, the macular edema, but point out that macular detachment there.
Well, the whole thing kind of is a macular detachment or schisis formation from here. And when I see going from disc over here, this kind of separation, I'm really thinking that we probably might have an infectious disease, but we certainly have the separation right there as well. So our differential diagnosis is extensive infection, infiltration, inflammation, demyelinization, and compression. So ordered MRI brain with and without contrast, MRI orbits with and chiasm with contrast and fat suppression. The important thing for everybody to remember in terms of neuroimaging to look at the optic nerve. The optic nerve has 4 parts. It's got a prelaminar disc. It's got a retrobulbar part. It's got an intracanalicular part, and there's a posterior orbital anterior chiasm part. In order to get all 4 parts of the optic nerve, you have to have brain orbits and chiasm with gadolinium and fat suppression. Also have to look CBC, SED-rate, CRP, ARNA, RPR, FTABS, ACE, zoster, rubella, toxoplasmosis, Lyme disease, Bartonella, Hensley, Quintana, P. ANCA, and C. ANCA. This is a large evaluation that I wrote up for this patient. Now, because he had some significant diabetic retinopathy, my wife referred him to our retinal specialist for a consult as well on the diabetes. By the time he got to our retinal specialist found out he didn't do any of the imaging, didn't do any of the serology. He tapped out and said, if you're not going to listen, you're going to go to the ER and let them sort it out. He didn't send the patient back because he feels this is a non-compliant patient. In the ER, the on-call ophthalmologist was an ophthalmology resident who did a CBC, said it was normal, Says patient only has diabetic retinopathy and doesn't need an MRI. Interesting, a resident tells our Bascom Fellowship trained retinal specialist it's diabetic retinopathy. Clearly a swing and a miss. So don't think that sending patients to the ER is going to guarantee anything right is going to get done. A lot of times you're going to end up the PGY1 resident. I'll give you a story, Greg. I don't think we ever talked about this one. This is for our audience as well. Resident, first year resident, you know, once they're in residency, they're expected to be ophthalmologists. And maybe they did a rotation in medical school, and that's about it. Well, first year resident it gets called to the ER. Older man comes with orbital pain. He reads the manual, figures out how to do it. This is like first week of residency. Figures out how to do a tonal pen. Tonal pen has pressure of 17 and about 75. Goes through his cheat sheet manual, looks it up. Okay, acute angle closure. Reads the medicines, pours these medicines into the patient's eye. Checks about 90 minutes later. Pressure is still about 75. All right, goes back to his manual, reads through. All right, comes up with some Diamox, gives the patient Diamox. An hour and a half later, pressure is still in the 70s. Goes back and looks at it, goes back and reads it again. Okay, now he admits the patient for IV mannitol. Next morning, when rounds are being done, third year resident is doing rounds, comes to the bedside, removes the patient's prosthesis, cleans it, puts it back in, and tells the first year resident, you can release him now. He was essentially treating a prosthetic eye. So don't just think shipping it to ER, the right thing is going to get done. Now, optic neuritis is usually painful, sometimes not. And that sometimes not really is a misdiagnosis. Anyone using the term occult optic neuritis, and what is occult optic neuritis? Well, you probably had an optic neuritis, but you just didn't notice it. I can tell you that doesn't happen. The patient really has to be somewhat incapacitated not to notice this. Anybody who used the term occult optic neuritis is really saying, I don't understand optic neuritis. She's a 48-year-old female who has sudden painful vision loss in her right eye of 2 days duration. She went to the ER where they did a CT of her head, which was normal. Why did they do a CT of her head? It's what they do. They're looking for an intracranial bleed. If they don't find it, they tap out. She goes to her PCP. Her PCP diagnoses zoster based upon her symptoms, but she has no dermatologic outbreak. She's prescribed Valtrex and prednisone, but she hasn't used either because she doesn't think she has zoster. And the patient was referred to me to rule out ophthalmic complications of zoster. Now, she's 20/60 in the right eye, 20/20 in the left eye. She's got a relative afferent defect, which you're going to expect for zoster unless we were dealing with a retinitis, which she did not have. Color vision was 14 out of 14 in both eyes, but she struggled mightily in the right eye, and she had retroorbital and temporal pain. And this is what she looks like. And what we see here is pretty normal optic nerves in each eye. There's no swelling, pretty robust cup in each eye. She has a relative afferent pupillary defect in the right eye. And we can see that she has some arcuate field defects in the right eye. Nothing to speak about in the left eye. So my approach in this is MRI brain orbits and chiasm with gadolinium and fat suppression of the orbits. I tell them what exactly that I'm looking for. I'm looking for enhancement of the optic nerve. I'm looking for a demyelinating lesion. So in order to get the optic nerve, we know we have a neuropathy here because she has an afferent defect and a arcuate defect on visual fields. We know that we're dealing with optic nerve. And again, to emphasize, and the only way we can get all four aspects of the optic nerve would be orbits and chiasm, and brain with gadolinium and fat suppression. And this is what comes back. Edema and enhancement of both optic nerves and optic nerve thickening, worse on the right, suspicious for optic neuritis. There's that diagnosis there. MRI of the brain, fairly extensive foci of abnormal T2 prolongation, predominantly about the lateral ventricles. Many of these are oriented perpendicular to the lateral ventricles, raising the possibility of demyelinization with optic neuritis. No hemorrhage or infarct, no mass, no midline shift, no discrete suspicion enhancing intracranial lesion. So she has an enhancement and thickening of the optic nerve, certainly on the right, suspicious for optic neuritis, and she has demyelinating plaques in her brain. Now, she's a very intelligent person. I have to tell her what I'm thinking about before I send her off for imaging. Now, when she comes back and we discuss her imaging, she's already looked this up and she has some questions. Are you sure it's optic neuritis? Well, she's got pain. There's an afferent defect. She's female. Her optic disc is normal, and her MRI it shows optic nerve enhancement. So if it looks like a duck, swims like a duck, and quacks like a duck, it probably is a duck. So am I sure it's optic neuritis in the absence of anything else? And I didn't do serology at this point. I feel pretty strongly that she does have optic neuritis. Now, her next question, is it an isolated demyelinating optic neuritis, or is it a clinically isolated syndrome? And of course, they don't say it this way. I can tell you, if she comes back and asks me, do I have clinically isolated syndrome? I'm getting nervous because she probably knows more about it than I do at this point. And at this point, I've got to say, yes, it is. Now her question is, do I have multiple sclerosis? Ruh-roh. All right, Greg, let's pull up polling question number 9.
Polling question number 9 is open.
And that polling question is, does she have MS? Yes or no? Is that the right question, Greg?
Probably. I just switched from it to check the chat box. Does she have multiple sclerosis is the question. Yes, no, and I don't know.
So that is what we're going to be faced with, or what you'll be faced with, certainly what I was faced with when I saw this patient in follow-up when I have her positive imaging.
So 3 minutes ago, a question rolled in. Was there a definite diagnosis in the infectious swollen disc case?
The answer is no. He was lost to follow-up.
Okay. What did the spinal tap show?
Spinal tap on this patient?
It just rolled in, so I'm going to say yes.
I'm not ready to share that with you yet. That came later, and we'll talk about why that is important in just a bit.
Okay, let's go back to the poll because we're caught up there. And display is yes 37, no 7, and I don't know 56%.
Okay. And I don't know is probably the best answer here. Followed by probably no. I can't say definitively yes at this point. But this is not a question that I am going to answer definitively. Do I have multiple sclerosis? I know top neuro-ophthalmologists on the university level who will not answer this question. This is a question that is best left for a neurologist skilled in demyelinating disease and multiple sclerosis. And this is who the patient's going to need. Now, she may ask, what is my risk of developing multiple sclerosis? I can't answer that. Her risk is about 75%. And should I be treated, and this again falls into the category of above our pay grade, and this is for a neurologist. But we do know that there is a penalty for not treating. And by treating, we mean treating with disease-modifying therapies. We're not talking about steroids. 45-year-old female. I saw her on an April for a comprehensive eye examination. Had been diagnosed with MS. She has the diagnosis, but she's under no treatment. She's not been following with a neurologist for several years. Had been on Capaxone, but not using for the past several years since her last pregnancy. So her exam is normal, except for some snow banking suggestive of an old pars planitis, which has a strong positive correlation with multiple sclerosis. And that was in April, and everything was pretty well normal. She comes back August, vision blur for the past several days, followed by pain, worse with eye movement. So she's only a 20/20 minus in the left eye, but she has a relative afferent defect, not there previously in April. And she looks like this, and we can see that she has a normal looking optic nerve in the right eye, and she has a swollen optic nerve in the left eye. We can see on the OCT that she is kind of off the charts there. We can see the swelling of the optic nerve very well in that left eye. And here's her visual field. Now this may or may not be persistent. I didn't repeat it, but this is certainly very, very notable here. So if it looks like a duck, swims like a duck, and quacks like a duck, she's got evidence of demyelinating optic neuritis. And this shows you that there is a penalty for not treating the disease MS. I mean, she had a relapse here. So rather than doing any imaging myself, I just reconnected her with her previous neurologist that you need to be seen. Sent him the information. Now she's on Ocrevus for infusion every 6 months for relapsing, remitting MS and progressive MS. And I've seen her 3 years for annual examination since then, and she has had no accumulation of disabilities. Now, demyelinating optic neuritis is a demyelinating focal event in the optic nerve. It can be idiopathic or involving only the optic nerve, or involving other systemic diseases, particularly we're talking about MS. 90% of demyelinating optic neuritis is MS. About 10% is neuromyelitis optica spectrum disorder and myelin oligodendrocyte glycoprotein antibody disease. And we'll talk more about those maybe in just a bit. A third of these will have a papillitis, and 2/3 will have a normal looking optic nerve. They'll have abrupt vision loss, 20/60 average, but it ranges anywhere from 20/20 to no light perception. There'll be an afferent defect. Dyschromatopsia, usually that's the first thing patients can complain to me of, more so than the vision loss. They lose color perception, and they complain of pain. It progresses for about 2 weeks with some gradual recovery, but there can be some visual deficits. And it's typically Caucasians, rare in Asians and people of color. And 92%, probably more, have painful vision loss. Now, we have a lot of information that we can continue to mine the data out of the optic neuritis treatment trial. 15 centers randomized to 457 acute optic neuritis patients that were treated with either oral prednisone, IV methylprednisone, or followed by an oral placebo. Now, at 6 months, all patients had very good recovery. In all groups, had very good recovery of vision. Not all patients, but patients in all groups had good recovery. The patients who got IV steroids followed by oral steroids recovered the vision faster, but by day 30, the difference was insignificant. But what was significant is the oral prednisone group alone were 2 times more likely to experience recurrent optic neuritis and more likely to accumulate disability and develop clinically definite MS. And probably it wasn't the route of administration, it wasn't enough steroid. Now, visual function after treated or untreated optic neuritis from MS will recover within about two weeks. Most recoveries by the end of the first month, but they can still recover up to about a year. If they don't start getting better within about the first 3 weeks after onset, it is considered atypical, and it may be some other condition. It may not be demyelinating optic neuritis. Now, MRI is critical in diagnosis and management. The 15-year results, conversion to clinically definite MS, 50% overall. Now, if their MRI was normal at baseline, only 25% converted, but if it was abnormal, it 75% converted. So our first patient had an abnormal MRI, so she had a risk of 75%. Lowest risk of conversion to clinically definite MS in this study, males, those who had swollen optic nerves, had no pain, and had no light perception. This is all so much of the antithesis of what we usually see that these were likely misdiagnoses. And they probably got into the study inappropriately. Now, a normal MRI at baseline and no MS at 10 years, then 2% risk at 15 years. I'll talk about dissemination in time and space in just a second, but we used to have a don't ask, don't tell approach. We didn't try to diagnose this because there is no treatment. Nowadays, we want to make a rush to diagnosis because there are interferon therapies that can alter the accumulation of disability. So there is a penalty for not starting immunomodulatory therapy at the onset. That's why they need to be in the hands of a skilled neurologist who has experience in demyelinating disease. Now, diagnosing, we have to have demyelinating events disseminate in time or space. Disseminating in time, 2 or more events occurring at different times, or MRI brain lesions identified as old or new. Now, the first patient, she had new lesions. She didn't have old lesions. Disseminating in space, 2 or more events occurring at different neurological areas. Now, without this, we have clinically isolated syndrome. It's a first episode of inflammation demyelinization. Neuroimaging's off the normal. It doesn't necessarily mean they're going to convert to MS, but a person with MS has had more than one episode. And about 63% of clinically isolated syndrome, just an optic neuritis, do go on to clinically definite MS at some point. Now, somebody asked about what did the CSF show? Well, her CSF showed oligoclonal banding. These are proteins in the CNS. That, along with the brain lesions, allowed for a diagnosis of MS. Now, this is relatively recent that they have included this as a criteria for diagnosing MS. That prior, using the McDonald criteria, prior to oligoclonal banding proteins in the CSF, you had more people with clinically isolated syndrome. Now, when we put that in there as a marker of MS, that goes down, clinically isolated syndrome goes down significantly, and the diagnosis of MS goes up significantly. So that is a new inclusion. But here's an odd one. The optic nerve is not in the criteria for MS diagnosis. Criteria for diagnosing MS does not allow the optic nerve to be considered an anatomical region. It can only be demonstrated in space by lesions in two or more of the 4 areas of the CNS, the paraventricular, cortical, juxtacortical, infratorial brain regions, and the spinal cord. Now, neurologists have come across, cases where they can't make a diagnosis because they can't consider the optic nerve. It doesn't count. So the fact that she had optic neuritis, Greg, and brain lesions does not make a diagnosis of MS. Now, if she had optic neuritis, new brain lesions, and old brain lesions, based upon the brain lesions, a person could be diagnosed as having MS. So they're looking at adding the optic nerve as an anatomical site in order to increase the sensitivity of diagnosing MS. So they're probably in the next go around the McDonald criteria update. Adding optic nerve involvement confirmed by MRI OCT or visual VEP to the criteria is going to increase the ability to diagnose MS and get patients on on treatment. So a clinical suspicion of optic neuritis, which leads us to do an OCT, which can be abnormal, or leads us to do an MRI, which shows enhancement, could eventually count in the diagnosis of MS and get patients on treatment. But up until now, optic neuritis itself is not even considered as part of the diagnostic criteria for MS. Anything come in, Greg?
Let me take a look. Nope.
Okay.
We still have, what did the spinal tap show?
She had oligoklonal bands. I'm going to kind of skip over NMO and MOGAD because they are demyelinating diseases. We can read that later. I'm going to talk now about in the last 20 minutes about, and maybe we can go back to it. I don't think we'll have time. Non-arteritic
just what are those, Joe? I know they're hot out there. If you can give the elevator speech, I'm getting ready to step up. What are those two conditions?
Those are two demyelinating conditions that are not MS that have different treatments and different prognoses. Now that when we suspect optic neuritis, we also have to order aquaporin antibodies and MOGAD antibodies in order to determine. And it's important because not all neurologists are really that savvy about it just yet. But I'm going to talk about non-arteritic anterior ischemic optic neuropathy. I got a question mark there, what we call NAAI and a NAON. This is how it should present. They're going to have ischemic risk factors, hypertension, diabetes, atherosclerotic disease, cholesterol issues, maybe even sleep apnea. It's something, you can have that, that range in there. 6-1 is an inferior field defect. We don't know why anatomically. And it's an arcuate defect, not altitudinal. They'll have a hyperemic swollen nerve and a disc at risk. 97% of patients with non-arteritic ischemic neuropathy have a 0.2 CD or less, and the others were just misdiagnosed. They can have progressive moderate vision loss. Unilateral bilaterality is uncommon. It's a little bit younger disease, but it can go all the way up throughout older age. Often they notice it when they wake in the morning and is painless. Case in point, 48-year-old male, painless loss of visual field, left eye. He's 20/20, but he noticed something was wrong when he woke up. Type 2 diabetes, hypertension. He's got a new onset inferior arcuate defect and a hyperemic, small, crowded, swollen nerve, a disc at risk. And this is your classic appearance of a non-arteritic anterior ischemic optic neuropathy. Now let's talk about that. You mentioned glaucoma being the #1 optic neuropathy, and that is correct, Greg. Non-arteritic is the second most common after glaucoma optic neuropathy. The only problem is it's overdiagnosed and is too often used as a diagnosis of convenience. Somebody has a swollen nerve, visual field defect, you've had a NAON, we can't do anything about it. Or there's disc pallor. I don't feel like doing an evaluation. You probably had a stroke in the eye and there's nothing we can do about it. It's a great diagnosis of convenience. There's no test that conclusively proves that, and even if there was, there's no treatment for it. So there's nothing to do. I don't like the nomenclature, Greg. It's diagnosed in the negative. It's not by what it is, it's by what it isn't. Now, those people out there that know Greg, or if you don't know Greg, I'm going to tell you about Greg. Greg Caldwell, he is a wonderful person. He's got very unique and terrific characteristics. And when I say the name Greg, people know that. They know that about him. Now, what if instead of saying Greg, I just say not George? Well, they don't know all the characteristics, wonderful characteristics of Greg. All they know is he's not George. That it's diagnosing in the negative by what it isn't. What we really need to do is consider that this is a primary ischemic neuropathy and understand that there are other diseases that can cause ischemia, but they're not truly this primary disease of non-arteritic ischemic neuropathy. Now, do I do serology imaging for all suspected ischemic neuropathies? If they don't follow these criteria that I have right here, if there's anything that is a hint of hinkiness, the answer is yes, I will look at it further. So better term is small vessel anterior ischemic optic neuropathy, because we're looking at a primary disease. So it should be NAION or SVEION. And should arteritic ischemic neuropathy be called that, or should it be called large vessel anterior ischemic optic neuropathy? I'm not going to win that fight, but Greg, we're hearing it here first. I'm trying to get this now called SVEION, small vessel anterior ischemic optic neuropathy, where you're sure it's not something else, and they have these vascular risk factors. Here's a 74-year-old male, 5-day history of line across his right eye. We see there's a superior loss. 20/60 trace APD. It is painless, but that's not really a hyperemic swollen nerve. There's a good degree of pallor in there. And this is a person that I did a full evaluation on, including imaging and serology. It failed to yield anything. He's a snowbird. He was heading back to Boston. He went to Mass Eye and Ear, where they either did an evaluation or looked at my evaluation and just agreed it's an ischemic neuropathy. But it was different enough that I did evaluations. Now, this can progress as long as the optic nerve is still swollen. You can get progressive vision loss. So deterioration, field, and function in the first 10 weeks does not exclude a diagnosis of non-arteritic ischemic neuropathy, and you don't need to do any additional investigation unless there are other features that are discordant. Now, is this non-arteritic ischemic neuropathy or small vessel anterior ischemic optic neuropathy? 63-year-old male complains of some blurry vision in his left eye, not certain how long, about 2 weeks. Terrible historian. 20/30 right eye, 20/30 left eye, no pain, afferent defect, swollen optic nerve. And you can see they're both small nerves with kind of a disc at risk. He has no symptoms of giant cell, but he was seen by another practitioner in another office in my practice, and she sent him immediately to the OR for a sed-rate C-ractoprotein. At the ER, they weren't sure what to make of what was going on, so they did the blood work and did a CTA, MRI, with and without consent. They actually a fairly extensive evaluation. So this is what he looks like. He's got a hyperemic, hemorrhagic, swollen nerve, a disc at risk. We can see some abnormalities here in the GCC. He is very, very thick with an inferior arcuate defect. Now, I saw him the next day. He had the neuroimaging. It was all normal. The serology was reportedly normal. I don't have anything conclusive on that. But he's hypertensive. He doesn't admit to high cholesterol until I point out he's on prevestatin. He says, oh yeah, that's why my cholesterol is normal. He's got borderline diabetes. He's not under the care of a PCP. He uses his wife's Ozempic for weight loss and blood sugar control. Had used Cialis about the time of his vision loss. He used it at 1 a.m. and went to bed after taking his hypertensive medicines. And he asked me, did I do this to myself? So that's polling question number 10. Is this non-arteritic or small vessel AAION, Greg? Yes, is that yes or no?
Okay, polling question is open. Well, here's a question while it's coming in. What is our responsibility as ODs to monitor diagnosed MS patients as they return for their yearly exams?
I think it's probably appropriate that we do nerve fiber layer OCTs. It's pretty well understood and agreed upon that you can have subclinical changes in the OCT and depressions and and loss of nerve fiber layer in the absence of optic neuritis. And that could be very helpful in communicating with neurologists. And I can tell you the neurologists in clinical practice don't really know this. They're only vaguely familiar with it. So follow up with OCT.
Yeah, I think an easy way, just do your regular exam, look at the optic nerve, make sure you're doing color vision, and do a nerve fiber layer, and you should be good.
Agreed. So what's the trend here, Greg? What do they think?
We got 84%. It just chipped back down to 83. 83%. I'm displaying it now, saying yes.
And I agree.
It's a small vessel.
It's small vessel anterior ischemic optic neuropathy. Now let's look at risk. The GLP, the semaglutides, and erectile dysfunction medicine. And keep in mind, a lot of these patients are getting and using these medicines without supervision. Normal disc, normal cup, no vascular diseases, there's minimal to no risk using these medicines. Vascular disease, high blood pressure, diabetes, sleep apnea, high cholesterol, normal cup to disc ratio, again, minimal to no risk to use these medicines. They've got vascular diseases and a disc at risk, it is still a minimal risk. Vascular diseases, disc at risk, previous non-arteritic or small vessel ischemic neuropathy, this is the highest, but it's an unknown risk factor. Probably a very small number, and they need to modify risk factors if they use these medicines. The biggest risk factor you can't do anything about is a small crowded optic nerve. Non-arteritic ischemic optic neuropathy in Black patients. Now, this is a population that usually has a large CD ratio. In patients of color, Black patients who have developed non-arteritic ischemic neuropathy, they all had small disc at risk. They had small cups. Now, using the semaglutides, GLP-1 medicines, association does not mean causation. Do we want them to stop? Are we going to tell them to stop using a life-saving drug? What about the erectile dysfunction medicines? Association is not causation. Are we going to tell them to stop using a life-changing drug? And, I hear it from these patients all the time. I used it once a long time ago. Translation, they probably used it last night. And they may even popped it before they even came to the exam. Now, you got a patient with high blood pressure, diabetes, small disc at risk. They use erectile dysfunction medicine. They have intercourse. They take their blood pressure medicines. They go to bed. Maybe they have some nocturnal hypertension, maybe some sleep apnea. This is the best potential for infarct, but it's very small. Now, they want to use erectile dysfunction medicines. Who am I to tell them no? I tell you, if you're going to do it, modify your risk factors that you can. Control blood pressure, diabetes. You can't do anything about the disc. You don't take your blood pressure medicines when you go to bed. If you find out if you have sleep apnea, use a CPAP. Or I also say, if you're going to use this medicine, why wait till the middle of a cold, dark night? Get yourself some afternoon delight. Okay, you don't have to use it at midnight. Take your blood pressure medicines and go to bed. Use it in the afternoon. You're going to decrease your risk. I'm going to pop over this one. Here is. Let's see. Do I want to pop over that? No. I'm gonna pop to this one because we're running up. We got about 5 minutes, Greg.
I have 9:10, so you have 10 minutes from my standpoint.
All right. Well, let's just talk about this one really quick. I won't do the polling questions. 65-year-old woman who has high cholesterol referred to me for her PCP. She noticed a shadow in her superior visual field that when she woke up. Painless, no headache, no jaw claudication, no weight, no malaise. She's not had any infectious exposure. She's 20/20 with an afferent defect, and she had a bit of a swollen nerve, superior defect. We can see the abnormalities here on the OCT, the thickness. So I did an evaluation, MRI, brain orbits chiasm with and without contrast, or ANA, RPR, FTA, BS, CBC, CRP, ESR, ACE, Bartonella, rheumatoid factors. Now, unfortunately, her GCA testing came back pretty high in the CRP and SED rate, though I knew she did not have temporal arteritis based upon her history and the stability of it all. But I still have to deal with it. So I got her on prednisone with her internist. We did a temporal artery ultrasound, which was normal. So we taped her off. All her other labs came back normal, except her ANA was markedly elevated at 1/12, 1 to 1280. Should be less than 1 to 80. And this is what I mean by we have to do evaluations of these suspected non-arteritic ischemic neuropathies. She really had to get to a rheumatologist, and he wasn't really sure what was going on. We decided she had an autoimmune neuropathy. He ran further panels, repeated the tests. Now she tells me she's being evaluated for autoimmune liver disease. So don't let this be a diagnosis of convenience. So I think my last two cases, 59-year-old male, retinal detachment end of last year. He had it surgically repaired elsewhere. Of course, develops a cataract, goes to one of our cataract surgeons. Before cataract surgery, he refers him to our retinal specialist to get retinal clearance. Retinal specialist notice disc edema left eye, refers him to me for a neuro evaluation. Now, he's got no symptoms for giant cell. He's got a small CD, hyperemic disc swelling, visually asymptomatic except for cataract, no sleep apnea, denies erectile dysfunction medicine use, but we all know what that means. Medical history, he's got AFib, for which he uses metoprolol and amiodarone. And this is what he looks like. He's got hazy view in the left eye from his cataract, but he's got a swollen nerve. We can certainly see the swelling on the OCT, and he has an inferior arcuate defect, got a nasal defect here, which I would write off as probably being just testing artifact from a rim. So I'm not going to do the polling question. Does he have arteritic anterior ischemic optic neuropathy? Well, he was 59. He does have an ischemic neuropathy. I did order the test. Comes back to ESR. Everything was very normal. What about non-arteritic? Is this your simple non-arteritic? He's got no vascular risk factors, but he's on amiodarone. The hate drugs, hydroxychloroquine, amiodarone, tetracycline, ethambutol. These are bad drugs. Amiodarone does mimic anterior ischemic optic neuropathy. So our approach is we contacted his cardiologist, who didn't even think he really needed to be on the amiodarone. We did stop it. And what I want to point out is over the course of several weeks, we can see the swelling is going down. The field loss is improving. But what I want to point out is look at that nasal defect here. What I thought was initially just a rim defect here is markedly showing up in each of them. He probably has had an amiodarone associated ischemic neuropathy. So
And
I'm going
that's
to wrap.
worth pointing out to the audience there, Joe, that most of us think of the whorl patterns that comes with that. And a lot of people think the whorl patterns cannot cause vision loss, and they can. They can cause an irregular astigmatism. I've changed people and their vision improved working with the cardiologist, but that's a rare one there. I'm pointing out it's the one everyone to realize that that's amiodarone, the one that causes the corneal whorls. Joe just pointed out one of the rare complications.
Well, I'm going to wrap up with this case. 78-year-old female, 1-day history of red, yellow, and blue flashing lights in the right eye the previous day. She awakes with painless, blurred vision in her right eye. She's 20/40 and 20/20. No afferent defect, but it's not been verified, so I can't tell you yes or no. She's got reflux disease and migraines. No symptoms of giant cell arteritis reported. She's got dyskendemia inferiorly in the right eye. The optometrist in our practice who first saw her thought she may have had an impending CRVL, refers her to our retinal specialist, who did an angiogram, saw pronounced disc leakage, and referred the patient to me for a neuro-op evaluation. So this is what she looks like. She's got a small cup, small nerve, small cup in the other eye. We can see some hyperemic swelling right there, and we have some hemorrhage in the retina. We can see that there's some GCC abnormalities. We can see the thickening inferiorly on the OCT in the juxtapapillary area. So painless vision loss. She knows that when she wakes up, she had red, yellow, and blue flashing lights the previous day. She definitely has disc leakage on the fluorescein angiogram in the right eye, and she looks like this. There's her small nerve, her crowded nerve, her hyperemic sectorial swelling. So is this non-arteritic anterior ischemic optic neuropathy or small vessel anterior ischemic optic neuropathy, SVAM? Greg, we got to get that into the lexicon. We've got to get that into the jargon. Let's look at it. It's monocular, good and bad, because arteritic can be monocular. Painless, that's good. Mild vision loss, that's good. Vision loss noted when she woke up, that's good. Sectorial hyperemic disc swelling, that's good. That's all part of the picture. But she's got no vascular profile, and that troubles me. 78 years old, that's neither here nor there. It can be either arteritic or non-arteritic. She's got no GCA symptoms, that's good. Her platelet and SED rate were normal. I did get those. That's good. CRP was markedly elevated. That's kind of bad. That might make me do a temporal artery ultrasound in some cases. But colored flashing lights is not usually something associated with non-arteritic. So we see everything here. My following polling question is this non-arteritic? Is it small vessel anterior ischemic optic neuropathy? Is it SVAN or NAON? Yes or no?
Okay. Polling question is open. While that's happening, let me make sure it's open. Yep, it is. There's a great question. This kind of rolls in, and I got a kind of question for Karen, if you want to put it in there, is that it's Joe. It says a new non-arteritic ischemic optic neuropathy, anterior ischemic optic neuropathy has not seen the PCP in years. Where do you send them to get medical workup? How fast? Urgent care.
If I really think this is small vessel non-arteritic anterior ischemic optic neuropathy, I'll do the evaluation myself. If you have any doubts, there's symptoms of giant cell arteritis, they have vision loss, you have to consider that the best place might be in the ER.
And that's where I was going with that, Karen. You kind of might have already worked them up if you did the workup for giant cell. Again, Joe was mentioning it that the non-arteritic anterior ischemic optic neuropathy is a diagnosis of the negative. So did you do anything or just use that criteria that Joe said? So we have to make sure that it is non-arteritic. Well, if it's non-arteritic, is it just based on clinical findings or did we do testing there? Now, if you did some testing because they were suspicious, they were over age 50, kind of you sent them for a SED rate, C-reactive protein, platelets, check the hemoglobin, and it looked normal, and they don't have a PCP. Now it could be related to all the other kind of diabetes, high blood pressure, the metabolic conditions. I think we have a little bit of a runway is, I would say 4 to 6 weeks, 8 weeks. It's going to be hard in these times to get them in. Sometimes you have to phone a friend that's easy. So it all depends on how much workup you've done there. If you know for sure, going with that diagnosis of the negative, that it's not something bigger, then I think you have a 4 to 6 to 8 week period.
So what does our audience think? Is this small vessel anterior ischemic optic neuropathy? Is this non-arteritic?
Well, you got 51% saying yes and 49% saying no.
Excellent. Well, what's the one thing that's missing here? Always do visual fields with dealing with any optic nerve disease. And I did visual fields on her, and this is what she looked like. Now you may wonder, why is it, this is just errant fixation. I can tell you these were all zeros. She's got a right hemiopic defect. She's got an inferior arcuate defect there. Nothing matches what we think of with non-arteritic or small vessel ischemic neuropathy. I got urgent imaging on an outpatient basis. And I can tell you, I got a phone call from the radiologist. And when that happens, it's usually a bad thing. So left hemorrhage, occipital hemorrhagic necrotic mass with surrounding edema. This represents a primary malignancy such as glioblastoma versus metastatic disease. Enhancement concerning for spread of tumor. Left to right midline shift 7 millimeters. That's huge. Papilledema. And findings were discussed with Dr. Sowka at 4 p.m. and patient was sent to the emergency room. The radiologist actually called me and we spoke and he told me what was going on. He said, "Can you help out? Do you know anybody at SMH Hospital? Can you get the patient in?" I said, "Look, I'll make a call to triage nurse." He said, I'm getting the films, the CD ready. I'm getting the report ready, and we're going to send it right to the hospital. If you can have them waiting for her, that'd be much appreciated." And we sent the patient off. And that's the reason why we don't use this as a diagnosis of convenience, non-arteritic. If there's anything that's unusual at all, we need to work it up. Now, I don't know if I've saved her life or not. I think it's got a grim prognosis. Maybe I prolonged her life, but it unfortunately doesn't look good. So there's just a little bit more left, Greg, but we're not going to make it all the way. So I'm not going to go any further. I'm just going to wrap it up and say, hopefully, of course, we can probably come back and do it again. Hopefully my B-sides were as good as these and that you got something out of it. So with that, Greg, I think we're going to call it quits. We don't want to overstay our welcome in show business. It's better to leave and wanting more than to overstay your welcome. So with that, I'm going to stop my share and let you wrap up.
Okay, perfect. I'm watching the quick chat box. It looks pretty good right now. It's empty. So everyone, if you look at where it says surveys, that little red dot has appeared. If you want to click that, go ahead and start your survey. And with that, questions. I don't see any other questions in here. So I want to thank everyone for attending. Glaucoma, yes. Glaucoma, no. Part 2. And other optic nerve conundrums, the B side. And Joe, I'm going to say that the B side is probably just as good or better than the A side. So thank you for doing this synchronous virtual course. Joe, you did a great job presenting this. I learn every time I hear from you and tying it all together and giving people maybe some calmness when they see these optic neuropathies coming into their offices.